cardiovascular pathology, infective endocarditis. All right, so let's define this first. We have an infection of the endocardial surface, okay? And that mainly involves our valves, okay? And before we enter anything else and talk about what's going on, we have to talk about the pathophysiology of what's occurring, okay? So we have, first and foremost, endothelial injury or damage to the valves, okay? And once damage occurs, right, our human response is going to form a vegetation consisting of platelets and fibrin at that location of endothelial damage. And that fibrin and platelets is going to create a really great kind of sticking point or petri dish for bacteria that are present throughout our body, okay? So we have to have that initial endothelial damage, which causes that formation of the vegetations consisting of the platelets and fibrin. And then that fibrin is always just a kind of a starting point for the growth of bacteria, a sticking point. Okay. And then once that bacteria is there, it's able to just eat away at the valve, causing multiple valvular pathologies. Okay. And then what we have to talk about is infective endocarditis. Okay. So the patient's going to present with fever most of the time. Okay. So if you see a patient that does not have fever, but they present similar to infective endocarditis, stop thinking about it. Okay. Because the most common presentation of infective endocarditis has to contain a fever because, once again, it's infective. That means there's a bacterial infection going on somewhere. Number two is the presence of a new murmur, okay? So if we have a murmur, that means that the valves are somewhat being attacked by something, okay? Then it could be a potential infective endocarditis, okay? But remember, that initial step of pathogenesis is the fibrin deposition, which allows for our bacteria to stick. Now, there's two things that can occur. You can have vascular issues or immunoglobulin issues, okay? So let's start off with the vascular issues. So as we form these platelet, fibrin, and microbe petri dish on the valves, okay? The valves are going to be consistently working, right? So they're going to be opening and closing, opening and closing. And that trio of fibrin, platelets, and microbes can dislodge and form septic emboli. So essentially you just get these the valve is spitting these fireballs out into the circulation that consist of essentially just like platelets and fibrin with bacteria in them, okay? So they're known as septic emboli. Okay, and these septic emboli, they're very small, so they're going to travel to our microvasculature, and they're going to cause our vascular phenomena, okay? So the first thing that we're going to see is a septic embolism, okay? And they're going to lead to petechiae, which is just like small dots on our skin, okay? Small red dots on our skin. You're going to see splinter hemorrhages, so they're going to travel all the way to the nail bed vasculature because they're so small, and they're going to cause splinter hemorrhages in the nails, and you can see what they look like on imaging. Just look up splinter hemorrhages. You're also going to see Janeway lesions. Janeway lesions are painless and erythematous lesions on the palms or soles of your feet. And once again, these are just because septic emboli are going through your microvasculature and they're getting lodged in, once again, the palms or soles for Janeway lesions. But you have to remember the Janeway lesions are painless and they involve septic embolism, okay? Moving forward, we want to talk about the immunological process, the immunological phenomena. So not only do we have these septic emboli being thrown off the vessel, okay, we also have these immune complexes, okay? And immune complexes are just a bunch of our antibodies, together with antigens, and they form these like clumpy complexes that can get lodged in different areas, in small areas, okay? So they're very similar to septic emboli, but they're made up of something else. They're known as immune complexes, okay? They're made up of our immune cells. And they deposit, okay, in different areas. And if they deposit now in the fingers or the toes, okay, similar to Janeway lesions, but it's immune complexes rather than septic embolism, they're called osler nodes, okay? And osler nodes are painful. So that's how you differentiate it. So if they say something that's non-painful, that's located on the hands and feet with the presentation of infective endocarditis, start thinking about Janeway lesions and say that the answer is septic embolism as the issue. However, if you see issues with the fingers and feet that has a presentation of infective endocarditis and they're hurting, okay, that means that they're osler nodes, and the reason is because of immune complexes, not septic emboli, okay? Second immune complex issue is Roth spots. So on the retina, you're going to see these little spots or hemorrhages, and that's known as Roth spots, and that's secondary to immune complexes as well, all right? Now, overall, infective endocarditis, what does it mainly affect? The mitral valve is most commonly affected, but the tricuspid valve can be affected depending on what is going on. So mitral valve mainly, but if it's the tricuspid valve, so if you hear a murmur at the location of the tricuspid valve, then you know you're dealing with tricuspid infective endocarditis, and that is usually secondary to drug usage. And the reason behind that is because drug users, they insert their needles into the venous system. That's where they insert the drugs. And so that's how bacteria, specifically for our drug usage, the bacteria that's going to be coming from the drug usage is going to enter the venous system, and it's going to attach onto the first valve that it sees. And it's on the right side of the heart, right? So the right side of the heart is going to first note the tricuspid valve. So that's why we see mainly drug users have tricuspid infective endocarditis. And the causative agent is usually Staph aureus, okay? But everything else is mainly mitral valve is the most common, okay? So overall, what I want you to understand from infective endocarditis is that it's essentially an infection of the valves, okay? And there's multiple causes, multiple bugs. So Staph aureus, as we said, can be due to infective drug use. And then you also have viridins, strep viridins, okay, along with multiple other organisms, which you will learn from your sketchy for microorganisms. The pathogenesis initiating step is that fibrin deposition, okay? So what we're going to have is the endothelial injury, which leads to the formation of the vegetations consisting of platelets, fibrin, and then fibrin allows for the sticking of the bacteria onto the valve. And then you can see two separate things. You can see septic embolisms, which can cause splinter hemorrhages in the nail beds, as well as Janeway lesions, or you can see immune complexes, which can cause ocular nodes or Roth spots. All right, so that's all for infective endocarditis. Next, we can have non-bacterial thrombotic endocarditis. This is lower yield, but what you will see comparing to infective endocarditis is the lack of a fever because you have non-bacterial thrombotic endocarditis. There's no bacteria, so there's no fever. Okay, so infective carditis has to have the fever. Non-bacterial thrombotic endocarditis does not have to have the fever. Okay, now you're also going to see sterile platelet-rich thrombi, okay, on both sides of the valve. For infective endocarditis, you only see it on one side of the valve. For non-bacterial thrombotic endocarditis, you can see sterile small vegetations on both sides of the valve. That's a giveaway. And they're mainly going to be talking about Liebman-Sachs. And Liebman-Sachs endocarditis is usually secondary to patients that have SLE or lupus. Okay, so lupus can lead to Liebman-Sachs endocarditis, which is a non-bacterial thrombotic endocarditis, which has sterile platelet-rich thrombi that dislodge easily, and the vegetations are going to be small, and they're going to be located on both sides of the valve. All right, so that's it for the endocarditis. We're going to be talking about rheumatic fever and the rest of the pathology later on.